Hi, everyone. This is Anna Hauser. For those of you that don't know me, I'm our agency clinical director, and today I'm going to be talking about suicide awareness and prevention. September is National Suicide Awareness Month, so we thought a good time to talk about this important topic. It's very important to us as an agency to discuss this with our staff and to ensure that we're feeling comfortable and well trained in how to address suicide and suicidal ideations. So the goals for the training today are going to be to overall just talk about increasing awareness, making sure that we're approaching care from a preventative stance, exploring specific risk and protective factors, and as we try to do in general, just really working to individualize our care of our participants from a person-centered perspective. We're going to be talking about specific language and the importance of selecting our words mindfully in a trauma-informed way. Again, really focusing on person-centered, culturally mindful care. And we'll discuss specifically our safety planning and risk assessment process at New Choices. This is something that we look to apply universally throughout all of our programs. And really also talking about recognizing the emotional needs of our staff. So we'll discuss some wellness and resources because we recognize that this can be a really emotional and challenging aspect of our work. So we want to take the time to recognize the impacts that it can have. So just going over some data specific to 2023, in the United States, over 5% of adults reported that they had serious thoughts of suicide. This number translates to over 12 million people, so a really significant scope. And specifically in New York State, we ranked number 7 among the states for adults with serious thoughts of suicide. So something that's very impactful with the population that we're serving. After a slight decrease in suicide deaths from 2019 to 2020, the number of individuals who died by suicide unfortunately increased in 2022, and we saw the highest numbers ever recorded in the United States. So specifically in our state, there has been $1 billion dedicated in 2024 to really overhaul and expand the mental health services that are being provided in New York. There have been specific initiatives designed to reduce social isolation, address mental health in adolescents, specifically construction workers, military personnel, and in the work that we do, we recognize that at times mental health care can be really difficult to identify. Barriers to care among some other high risk factors and populations include people in rural communities where that access to care can be particularly impacted, folks who are socially isolated. We see increased prevalence in males, older folks, adolescents have very specific factors that influence suicidal ideation and attempts. People that have served in the military, those that have an experience of trauma, our LGBTQ population, 1 in 5 of whom report an attempt in the last year, and then participants who do not have healthcare services delivered in their language can be an additional risk factor. So specifically per SAMHSA, substance use disorders are associated with an increase in the likelihood and severity of suicidal thoughts and behaviors, as well as suicide attempts and deaths. So important to consider how suicidal ideation impacts the clients that we're serving for substance use disorder treatment, really making sure that we're acknowledging and caring for their co-occurring mental health challenges to make sure that we're working to keep people safe and address the emotional challenges and behaviors that they might have going on. So thinking about inclusion and sensitivity and language, I'm going to make sure that this PowerPoint gets sent out so that all of the resources are available to you. And so there's some specific language that we'll talk a bit about using terms like mentally ill. We want to try to avoid, and not define someone by their experience with a mental health diagnosis. So using terminology such as person living with a mental health condition, person who has struggled with mental health, same going for victim or survivor, kind of not polarizing experience, but talking about someone has been impacted by. Also, I think it's important to consider the participants' use of language when they're describing their own identity or experience and to incorporate some of their own terminology. Going along with talking about the use of language, thinking, of the importance of language in how we're facilitating suicidal screenings, which we'll talk a little bit more about. But the Psychiatric Times specifically released some information around just the most effective screening being one that actually happens. And even though we know this is a really difficult topic to address, it can feel uncomfortable sometimes, but we don't want to ever make assumptions based on a client's presentation, appearance, identity, and not ask about suicidal ideation based on our own assumptions. We want participants to be asked no matter who they are or how they seem, and just a reminder that the way we ask a question has an impact. So some other replacement terminology and why to state that someone has died by suicide, death by suicide, lost their life to suicide, rather than using the word commit, which can imply that suicide is a sin or a crime and kind of perpetuate some of the stigma that we see around suicide. Trying to use more neutral phrasing just in general to kind of take away any type of shame, blame, judgment element. Using terms such as, similarly to died by suicide, but to describe an attempt as a fatal or non-fatal, again, just to try to be matter of fact, not classifying something as successful. Terms like epidemic, skyrocketing can spark a lot of panic. So we want to talk about rates rising or increasing, kind of less emotionally charged terminology. Instead of saying that an individual is suicidal, we don't, again, want to define someone by their experience. So saying someone's name and then that they're thinking of suicide, has suffered through suicidal thoughts, experienced suicidal thoughts, rather than describing that person as being suicidal. These are all really good topics to discuss further in supervision if you have particular questions or situations that you're struggling with. We'll talk a little bit more about the importance of incorporating colleague and supervisor support into suicidal assessments. So again, just screening and assessment, we use an evidence-based screening tool for suicide risk, the Columbia Suicide Severity Rating Scale, which is mentioned here. Sometimes knowing how to approach the need to utilize the tool can be a little bit challenging. So some suggestions about introducing the topic, I'm going to ask you a few questions about suicide. I have a few questions to ask you about suicidal thoughts and behaviors. Stating factually, have you thought about killing yourself or wish to be dead? Have you thought about carrying out suicide? Asking in very frank language. Have you ever tried to take your own life? Have you ever attempted suicide? I think it's really important to, in a neutral way, present these questions. Sometimes we might feel the instinct to kind of lead a response when we're asking a question. So we want to try to refrain from saying things like, you haven't thought about suicide, have you? Additional factors to consider follow-up questions. Can you tell me more about the suicidal thoughts? What brings them on? When was the last time you had these thoughts? How strong are they? How long do they last? How easy is it for you to put these thoughts out of your mind? Again, follow-up questions, we want to try to deliver them as neutrally as possible. I think definitely indicating to a participant that you recognize that they might be struggling with some of these thoughts, but we also don't want to convey a hugely emotional reaction and put the individual who might be experiencing thoughts of suicide in a position where they feel like they might have to minimize or caretake for us. We want to try to navigate that emotional response to some of their, some of what they share with us. So to talk about some specific warning signs that are good to take note of, might indicate to us that we want to assess further with a participant, additional risk factors that can come up. Take a couple minutes just to look over some of this. And again, I'm going to send out the PowerPoint so you'll have time to review this information in some more detail. Just to name a few, when folks are expressing that they're experiencing unbearable pain, talking about suicide, talking about being a burden, really significant depressed mood, increased use of substances can be a warning sign, isolation, visiting or calling people to say goodbye, giving away their possessions, and some risk factors can include previous suicide attempts, any type of recent loss of a friend or family member to suicide, significant bullying, having the combination of substance use and mental health, access to harmful means, all factors that we want to consider. And obviously, none of these warning signs or risk factors automatically indicate that someone is struggling, but might indicate to us that we want to take particular care in how we're monitoring a participant or the kinds of conversations and safety planning that we're facilitating. So some protective factors that we know contribute to keeping folks safe when they're able to identify reasons for living. We ask about this question on our safety plan, which we will go over in just a few slides. Being substance free, having access to mental health care, feeling trust and safety with providers, feeling that they have the language to describe their emotional health and experience, feeling connected to a support system, having problem solving and coping skills, limited access to lethal means, and we find that cultural and religious beliefs that encourage connection, help seeking, discourage suicidal ideation, and create a strong sense of purpose or self-esteem. Ways to really take action steps to help someone in emotional pain include asking how they're feeling, asking those questions about suicidal thoughts, reducing their access to lethal means to keep them safe, being present for them, help them connect, and stay connected. Checking in on people really goes a long way. If you have a session with someone where it's clear that they're in significant emotional pain, following up, staying connected, checking in can be really beneficial. So some risk factors that specifically apply to those struggling with a substance use disorder, previous suicide attempts, any type of emotional health disorders, when they're struggling with active use, having that family history, hopelessness, evidence of self-harm. I won't go through and read every single one of these, but really important that we're knowledgeable and able to connect to recognizing some of these risk factors that can increase someone's likelihood of either attempting or dying by suicide. So supporting and safety planning at New Choices. On the left is our specific safety plan for all of our programs. This is a plan that you want to use when somebody is presenting with any thoughts of suicide. If they have a history of recent suicide attempts, very important that we're putting some concrete planning into place. And even if they're just really struggling, I think using this safety plan can be really beneficial if a person is having difficulty and would benefit from having some quickly accessible resources to them. On the right is the Columbia Suicide Severity Rating Scale. You want to ask these very specific questions about whether or not someone has wished they were dead, wished that they would go to sleep and not wake up, or had concrete thoughts of killing themselves, if they've had thoughts about a plan, if they have intent, means. There are certain instances if someone is presenting with active suicidal thoughts, with a plan, with an intent, you absolutely want to consult with a supervisor, with a colleague. Very important to be utilizing that collaboration in order to determine what are the next steps that need to occur to keep this person safe in a way that also honors our therapeutic trust and rapport with the person, but ensuring that we're doing our due diligence to really prevent suicide if we feel someone is extremely at risk. Any questions or concerns about our safety planning or procedure, please discuss with your supervisor or with me. We welcome any questions and are happy to talk further about our process to make sure that everyone feels comfortable and confident that even though it's really difficult, they would know what to do, how to respond if a participant was presenting with thoughts of suicide. I just wanted to share some additional resources that'll be available through the PowerPoint, but the Office of Mental Health recently put out this guidance for specifically how to make homes suicide safer. Again, talking about warning signs, when to call 911. We're going to talk further about the 988 Suicide and Crisis Lifeline. There's multiple texting resources. There's the Trevor Project, a lot of really good foundations and agencies that aim to reduce suicidal ideation and folks dying by suicide. This is the second half of that brochure, goes through specifically areas of the house that can be of higher risk if someone is struggling with thoughts of suicide, there's a QR code for some additional supports and suicide safer tips. So the 988 Suicide and Crisis Lifeline is something that we now have listed on our agency cards. So the 988 number was launched in July of 2022. 988 and 911 are two separate services with separate contact centers. 998 is available for any problem causing distress, including thoughts of suicide, free and confidential. It's available in multiple languages. They can help facilitate referrals. And 80% of calls to 988 are resolved over the phone. The other 20% usually require agreed upon mobile crisis, all other follow-up services, and currently less than 2% of calls to 988 require police involvement. That only happens if there's an imminent risk to someone's life, but in 98% of the cases, they're able to utilize alternative mechanisms of helping to keep someone safe. You also don't have to provide any personal information to keep it confidential. So in discussing all of this, I want to take a moment to kind of just return to our practice of discussing staff self-care, noticing the signs of burnout, managing these types of challenges for our participants can certainly put us at higher risk of burnout. Things like irritability, frustration, ruminating about work, feeling negatively or detached or overwhelmed, significant fatigue, sleep problems, memory concentration difficulties, reduced performance, calling out of work a lot, tendency to isolate. Some ways we can support ourselves in doing the work that we do is to identify what we can and cannot control, just kind of having that ongoing self-awareness when we feel a moment of high stress, having that self-dialogue. Why am I feeling this way? What am I holding on to and why? Is this something that deserves my stress, or some effective questions to kind of pose? Making sure that we're protecting our boundaries and taking space from work, monitoring your inner emotional energy to kind of be aware when you're struggling, knowing that we can reach out and tap into our resources when that happens, engage in regular exercise, other restorative activities that are specific to you, spending time with your friends and family, having that positive connection, looking for ways to connect, and also just really paying attention to yourself for warning signs of burnout. Please don't hesitate to reach out to your supervisor or a colleague, myself. We're all here to support each other in doing the work that we do. I want to mention also our EAP that's available. There's a contact number and a website listed here, and the EAP is available to all of us at no cost. It's completely confidential from your supervisor or any agency staff, and it's available to each of you as well as your immediate family members as employees. I also put a couple of other resources on here that our nurse at the 840 clinic, Jackie, who did a ton of research for this presentation, but also very specifically carved out space for these resources. They can be utilized with our clients, for us, for folks that have experienced the loss of someone very important to them to suicide. There's foundations available for support. The one at the bottom specifically offers camps for grief related to suicide or overdose death. So some really good resources we wanted to include here. And just a reminder of, with a lot of this pain and suffering that we talk about, there's also resilience. This quote I really like: when we learn how to become resilient, we learn how to embrace the beautifully broad spectrum of the human experience. And getting to sit with people, in their discomfort, in their pain, in really challenging moments is something I'm really grateful to be able to do, and I'm really grateful to be able to do this work with all of you. So thank you for your attention today. Again, please don't hesitate to reach out with questions, and I hope everyone has a wonderful rest of the day. Thank you.